Provident Healthcare Partners is a healthcare investment bank that is focused on transaction advisory services. We created this podcast for healthcare executives, entrepreneurs, shareholders, and providers who are interested in learning more about the world of healthcare consolidation.
Thanks for tuning into Providence Healthcare Dealcast. This is Craig Sager. I'm a director here at Provident Healthcare Partners. I will be your host today. In today's episode, we're going to be taking a deep dive into everything primary care, which is one of, if not the most talked about verticals across the healthcare sector. I'm joined by my colleague, Dustin Thompson, a director here at Provident, who co-leads our efforts with me in the primary care space. And our guest star, Jonah Broulette, a principal at Milliman, which is a leading consulting and actuarial firm with a deep focus across Medicare and Medicare Advantage. In today's podcast, we're going to hit on a few topics. Firstly, we're going to cover kind of the history of primary care and the current state of affairs. Secondly, kind of dive into what is all this talk about value-based care and taking risk and why it matters for a lot of the independent groups out there that are fee-for-service oriented today. And lastly, when we think about valuations in primary care and how we value an attributed or covered life, what does that all mean and how do we get to the roots of that? And so quickly for the audience, Provident Healthcare Partners is a leading sell-side healthcare-focused investment bank based out of Boston. We also have an office in New York City. We have 30 professionals. Our bread and butter is to represent healthcare service organizations across the United States that are looking to lock hands with a strategic or capital partner as they look to grow their organization and take the next chapter in the evolution of the business. We represent groups that are predominantly in three industries across healthcare. One is physician services, which is kind of where primary care will fall, and we'll get in that today. That's our biggest coverage area. Secondly, we do a lot of work across post-acute, so home health, hospice, unskilled care, anything really serving into the home. And then the third bucket would be behavioral health and all of the subverticals that fall there. We cover healthcare services outside of those three buckets, but that's where we do a lot of our work. Providence coverage in primary care, we have done over 10 transactions in the space for a number of reasons. I think groups look at primary care as really the central to healthcare, being associated with better population health, improved patient outcomes, and lower cost of care. It is far and away the largest space when we look at types of physicians across the country. And it's just a very evolving vertical with strong tailwinds that we're excited to dive into today. With that, before we get into our topics, would love to have you introduce yourself to the audience, Jonah, personally and professionally, and would love to hear more about what Milliman does.
Yeah, thanks, Craig. I'm Jonah Broulette. I'm a principal and consulting actuary at Milliman in New York and Atlanta health offices. I've been with Milliman for about 15 years, and throughout that time have been consulting primarily to provider clients, which is a relatively new space within actuarial and healthcare consulting, but one that's been growing rather fast over the last several years. What we do at Milliman is we work with clients who are taking some form of financial risk. Historically, that's been health plans who are taking financial risk through premiums for covering lives under healthcare. And that's been in commercial, Medicare Advantage, Medicaid. What we're doing today is a lot of financial modeling for non-health plan-based entities, such as primary care groups and provider groups that are taking risk within Medicare, often now within fee-for-service and Medicare Advantage. So our expertise is looking at the mechanisms of the program you're taking risk in, understanding what your financial risk is and how you can best perform under those programs, and benchmarking and data that we have available to enable such parties at risk to manage their risk in the best way they can. So identify areas of greatest opportunity for managing cost of care down, identify the profiles of patients that will be favorable and accurately benchmarked under programs, and identifying areas of focus within those contracts that will lead to success in the programs. And so a very large portion of my work and my firm's work today is based around analyzing and projecting financial risk for entities that have traditionally not taken financial risk over the history of healthcare.
Thanks, Jonah. And for those listening that have not heard of Milliman, they have a ton of clout in this space. They do awesome work. And Jonah specifically, when we represent groups in this space, a lot of groups, before they go to market, you obviously have your marketing materials. You'll do a quality of earnings, which essentially is financial due diligence on yourself, right? To show groups that you sort of check certain boxes there. But what we also do is we've been working closely with Jonah and his team on our primary care mandates to really look under the hood and look at a lot of the metrics and how we ultimately can portray that to potential partners on the various worth and risk across patient populations of our clients. But appreciate that, Jonah. Let's jump into the kind of the first topic here, which is more setting the stage. What's going on in primary care? Why is it getting all the attention? I will kick it over to my colleague, Dustin. Would love an introduction, Dustin, on yourself and really what you're seeing in primary care today.
Thanks, Greg. I'm Dustin Thompson. I'm a director in the Boston office, Provident, as Craig mentioned. I've been with Provident since September of 2013. Prior to Provident, I spent several years in public accounting, where I was in the healthcare subsector. We have seen primary care continue to evolve. CMS has mandated that a value-based care model be implemented by 2030 for all Medicare beneficiaries. Today's market is 70% fee-for-service, which sounds significant, but it has slowly been transitioning, as this fee-for-service used to be nearly 100% in the 80s. And that is when we started to see the value-based care model being implemented. Primary care is the largest vertical and has the most physicians, which is why we're seeing significant attention being dedicated to it today. We're seeing some of the largest deals as far as size, volume of physicians, and dollar amounts, with public traded companies being turned private or joining other publicly traded companies. Why we are seeing so much interest and discussion in primary care today is ultimately based on this movement to turn value-based care into the predominant payer by 2030. Within primary care, we have the traditional clinic-based groups. We have pediatrics. We're seeing multi-specialty, home and community-based, senior living, the value-based care enablers, direct to employee, and concierge. And that is why it is the largest makeup of single specialty there is, because we have all these subspecialties underneath it where we don't see that in many other verticals. There's tons of money getting poured into it today, and we expect that to continue to increase on a go-forward basis. Historically, there has been less M&A compared to some other subsectors, but that is quickly changing as primary care and especially Medicare Advantage seems to be one of the hot topics that everybody is discussing today.
Thanks, Dustin. Very insightful. And just to piggyback off of that, we all have probably heard that the primary care physician or provider serves as the quarterback to the healthcare system. And that could not be more true. When you look into the numbers, they influence more than $2 trillion of downstream annual healthcare spending per year. Yet they only make up 40% of the visits. So they have a significant impact on the healthcare industry, and certainly payers. And now, as you've seen over the last 5 to 10 years, investors are not blind to that. So it's an incredibly evolving and dynamic space. Jonah, from your view, what do you see in the industry and the landscape? And if we were to unpack funding sources and what's going on at the regulatory level, would love to hear your thoughts around the industry.
Yeah, certainly. So within the healthcare space, completely agree with the characterization of primary care as the quarterback of the system. When we seek to attribute patients to who is responsible for their care, generally all the models that we find today attempt to attribute total cost of care to a primary care doctor. All other models are some form of episode-based groupers. So certain episodes of care can fall within other specialties, but generally we are finding that primary care is the sort of the lifeblood of how patients receive care within American healthcare. The various funding sources that physicians participate in are Medicare Part B, that's Medicare traditional fee-for-service, Medicare Advantage, Medicaid, and commercial. And really the two biggest pies there are Medicare fee-for-service and Medicare Advantage. The reason for that being that the most care that we need to deliver to American healthcare beneficiaries is within the Medicare eligible age bracket. Note that Medicare takes responsibility for a large portion of care as soon as you become eligible for Medicare. So at age 65, if not sooner for other reasons. And even if you are dually eligible, for instance, a Medicaid and Medicare beneficiary, your coverage is first. A lot of the care that we're most concerned with, inpatient admissions, traditional physician visits, is going to be covered first by Medicare. So for all of those reasons, Medicare, both fee-for-service and Medicare Advantage, has been a huge focus of the regulatory space and generally the industry. That's where most of the dollars are being spent. And therefore, if we're going to look for solutions, if we're going to look for alternative ways to invest our money in healthcare, those are naturally going to flow first to the Medicare lives, where all the scale and all the volume is. And we typically find that the first areas that physicians are taking risk in these days would be in the Medicare space, because that's where the dollars are. That's where it makes sense to structure a risk contract, because really what makes a risk contract worth engaging in is that there are dollars there that need to be managed in some material way. And I'll get into what CMS and CMMI have done, but what you'll see in all of the models they have created to date that are total cost of care, they have defined a subset of primary care services that generally are being provided by primary care physicians that attribute patients. So their models, all starting with Pioneer in the early 2010s, the attempt there has been to identify beneficiaries who are at risk for the Medicare Trust Fund within fee-for-service and attribute them to a primary care physician via claims. So CMS goes in, they look for the treatment that is being received by the beneficiary, either in a prior year or in a current year, and they attribute them to that doctor and put that doctor at financial risk for all of the care that that patient is going to receive over the next year, or possibly over the next year plus, if it's been prospective attribution. So we started off with Pioneer. We then got MSSP, which right now is the largest and most significant program within Medicare. It was launched as part of the ACA. It's also guaranteed. So that's actually managed not by CMMI. We have two entities that manage programs. We have CMMI, which introduces programs somewhat flexibly, somewhat on a, every 5 years or so. We started with Pioneer, then we got NextGen, and right now we have direct contracting, which has become ACO REACH. Those are the programs CMMI sort of pilots. And then CMS proper, sort of a larger regulatory body and has to go through rulemaking, manages the Medicare Shared Savings Program, MSSP, which has the most enrollment right now and is what most people think of first when they're thinking about ACOs, accountable care organizations within the Medicare space. MSSP has been around now for going on, I think, 8 or 9 years, and has generally been accompanied by a more advanced, slightly different CMMI model. But again, the general premise of these models has been the same. Find ways to attribute otherwise non-risked lives to groups of primary care physicians who are willing to take risk for them and give them total cost of care risk. So the majority of what's being managed in these programs by the doctors who are being attributed to patients are, as you pointed out earlier, Craig, are not services being provided directly by the primary care doctors, but services that we think the primary care doctors exert meaningful influence over. And most notably here, we've seen pretty decent growth in the ACO space over the past several years. What we're expecting, based on the current rhetoric of CMS and CMMI, is that their goal would be to get 100% of the fee-for-service lives covered under risk by 2030. So I think right now we might have about 30% of fee-for-service lives covered and under a value-based care arrangement, and CMS would like that to be 100% by 2030. So whether they reach that goal and how fast they reach that goal is up for debate, but it certainly seems at the moment that the explicit goal is for all of Medicare fee-for-service, so all of that trust fund, either through Medicare Advantage or Medicare fee-for-service, to be covered under some form of total cost of care risk arrangement, which is certainly going to be an interesting new state for Medicare healthcare to be under, as we've never seen that before.
Thanks, Jonah. I think the follow-up question to your commentary there, at the most elementary level, I think we all know that Medicare Part B and Medicare Advantage does get the most attention from a patient population and payer standpoint. Is it as simple as those lives, the total cost of care for them are just significantly higher, and that's where the dollars are compared to Medicaid, commercial, duals, et cetera?
Yeah, great question, Craig. I think it is largely as simple as that. Those lives have the most healthcare needs that need to be managed. So there are more dollars flowing in there and more potential interventions there. For many Medicare beneficiaries, there is near constant care that is being delivered, even if it's just regular primary care wellness visits. There is something happening within the healthcare system for the majority of Medicare covered lives throughout the year. Multiple touch points for understanding what the risk of that patient is and potential for spending for that patient on healthcare services. Whereas within Medicaid and commercial, the pattern looks a little bit different. Within Medicaid, there is a good amount of spending. A lot of it is regulated spending. A lot of it is expected spending. What you will see in Medicaid is even under the risk contracts, a lot of what's being structured there is a regulated budget, but a budget that pays for a lot of things and does not change drastically over time, perhaps grows slowly over time, but is not being influenced away from high spending events and particular areas where we want to save money. There certainly is cost avoidance in commercial, but again, much less frequent touch points with patients there, much less expected care to be delivered. So really what makes Medicare unique is we are treating these patients regularly and we are having regular opportunity to manage and promote best care for them.
And Dustin, I would say spin that into the clients and groups that we work with and general conversations with primary care groups across the country that we have. How informed do you think these independent groups are of a lot of what Jonah just covered? And what are the, I'd say, biggest pain points that they come across running their primary care organizations?
Yep. So they are all very informed of options out there for value-based care. What they sometimes struggle with is how they're going to transition from the fee-for-service landscape to a very complex value-based care model and where they go from there. There are a lot of value-based care enablers, payers, and vendors that are continually reaching out to, our prospects and clients, offering their tools and services. But where exactly these vendors can help is the question that the shareholders or physicians are often arising to. There's many practices that are really struggling with the buy-in of the value-based care, since historically they've been operating successfully, and it goes back to, if something's not broke, why do they necessarily want to fix it? But that doesn't mean they're against value-based care by any means. They're just still exploring that risk model. They hear about the potential upside of the shared savings, and oftentimes, or I should say maybe just sometimes, they're skeptical if they should really be fully buying into this risk model and the shared savings. Is it a question whether it's all talk, or at the end of the day, are they going to, I'll say, realize additional income or value for not only themselves, their practice, but all their other providers and employees as they share it? I think everyone knows that they're sitting on a lot of value as we transition from a fee-for-service to value-based care landscape. But unlocking that full potential of value is something not all groups realize how they're going to go about it, as well as the steps needed and really the time frame there, because it's critical to properly implement this risk so the value can be realized. And it's not something that you want to jump into overnight and approach incorrectly, since there is tremendous upside from a value creation. When you take on full risk, there is also can be downside issues that we want to make sure we're implementing correctly and in front of.
Right. I think that's well said. When you have the Agilon Healths, the Alidades, the Pearl Healths of the world constantly knocking on your door, and they wave all these spreadsheets in front of you of what it could look like, under their program or their ACO or their tool. It looks flashy, but the execution on that, I think a lot of our groups, again, I don't know if skeptical is the word, but when they want to learn more and they become to a degree overwhelming, it's not that they don't believe it. It's just trying to run a business and make this massive shift into a kind of a new line of thinking. Very, very difficult. As we switch to topic number 2 here, which kind of is a nice transition, moving to risk and why it matters. Jonah, I think there are 2, I would say, camps that when we work with our groups that we see, right? They'll have a good chunk of Medicare Part B lives. They'll also have Medicare Advantage lives, obviously across various different types of MA groups. When groups are navigating that and they're being approached by these ACOs and other, again, enablement tools, what are the various financial arrangements that groups will enter into, and what is the pathway when considering putting these lives at risk?
Yeah, so we're certainly seeing many physicians in the space, providers in the space, have a significant footprint of patients within MA and within fee-for-service. And the options are quite different. I'll start with MA. That's the one I think most people are familiar with. MA, the risk is generally managed by a health plan type entity or an entity acting sort of traditionally as we would think of a health plan acting. And so what they're doing is they're basically taking full capitation risk for a population of patients who are going to enroll by choice. These people are seeking out an MA plan. They're going to choose one based on the benefit design, based on the premium, all the general considerations that people have when choosing a health plan. And those patients need to receive care. And the health plan's job within MA is to gather a network of providers that can provide that care. They need to provide similar care to Medicare fee-for-service, but notably, they are not operating under the fee-for-service, choose anyone you want to go to. Any service that you need to have provided will be provided without restriction. MA plans are operating, again, as health plans. They have limited networks. They have narrow networks if they want. They have pre-authorization that they can introduce, various forms of sort of patient control to help guide the patients through the healthcare system and getting the services they want from the providers that they deem appropriate to receive that care. So that's the MA space. So when providers approach to take on risk within MA, they're often being approached to take on limited risk within that full cap arrangement, right? Whoever's at the top of that MA plan is taking the full capitation risk, and they are trying to find various partners to take skin in the game as well to make them more successful. But again, you're operating within a system that has a lot of levers to pull in terms of narrow networks, how care is received, how care is flowing through the system. In many of those cases, the primary management or the full management of the patient within MA is not necessarily just down to the primary care physician or the physician that participating in that program. And their participation may, in many ways, be negotiated from a position of either relative strength or relative weakness relative to the MA plan, right? That's a negotiation. We want you to take risk for these lives. Here's how your reimbursement might look for caring for them. Here's the either full or limited risk you may take. So it's all open to negotiation. It's all down to market dynamics when you take risk on the MA side. On the ACO side, it's quite a bit different. Care is going to be provided just like it is in Medicare fee-for-service, and you're going to be taking risk for how those patients end up seeking out care within the system. But what Medicare is going to do is you're interacting directly with Medicare. They're going to give you patients. They're going to identify patients they attribute to you. They're going to tell you historically what they have spent, and they're going to give you a benchmark for those lives, a rough benchmark. Again, in MA, pretty much everything is known. You know your benchmark right from the start. You know what portion of risk you're taking. You know a lot of things upfront, and you're managing in a system that's been going for years and years and years with relatively small updates. But the budgets in MA are fairly well understood, and they're much more static oftentimes. In Medicare fee-for-service, you may have never seen your historical spend on these patients or thought about total cost of care because you've had no previous reason to look into that cost or understand what it is. What Medicare is going to do is they have 100% of claims data. They're going to run for your physicians who they think is attributed to you. They will tell you that. They'll tell you their historical spend. They'll also tell you regionally on a risk-adjusted basis what the average spend for like beneficiaries to yours are. Right now, that's pretty non-sophisticated. It really is just total cost of care divided by risk is how they're risk adjusting, which works fairly well over large populations, can work less well over the smaller populations. And they're going to give you a benchmark for your population based partially on the historical buildup of your expenditures. So how much you previously have been spending on them. Typically right now, that's 3 historical years. And for most programs, when they start, it's the 3 years immediately preceding the program start. ACO REACH started back in 21. And because of the pandemic, the benchmark years were used 17, 18, and 19. So they used years prior to that happening. In MSSP right now, if you were to start an MSSP today, your benchmark years would be 21, 22, and 23, which still hasn't completed yet. Those would be the 3 historical years that CMS looks at to determine what should we price your patients at. And again, that price will be based on the total cost of care being sought out within an unrestricted Medicare fee-for-service space for beneficiaries who you are treating in a primary care setting more than anyone else, essentially. You deliver a plurality of the primary care to these lives. And that budget that you get will actually not be set in stone. It will update. So it will update based on what all other Medicare fee-for-service lives trended at historically until the performance year. So the main difference between MA and fee-for-service is in fee-for-service, you're generally, as a physician, probably taking on a much more significant proportion of the risk. You might, depending on how experienced you are in the program, you might be getting upside only risk, which means you are not exposed to the downside. CMS has made most of their programs to date with many years, several years at least, and for some groups, even more than that, with no downside risk. So they get a budget, but you're not penalized for coming in over budget, but you are rewarded for coming in under budget. And that budget, again, is set with historical claims, mixed somewhat with a regional rate. So a partial regional rate, which generally in MA, it's all a regional rate. In fee-for-service, you're going to get a historical representation of how much your patients have cost mixed with a regional rate, oftentimes less than 50%. So oftentimes much more heavily weighted towards your historical spend. And you're going to be asked to perform on that plus some trend that CMS will determine later. So you're flying somewhat blind. You have a decent idea of what your budget is. There will be variables at play that determine your success in the program. I think a key thing to think of is there's less certainty in the ACO program, but it does flex, we think, better with what is actually happening in the market than an MA plan can. MA is more well understood. Again, it's more regulated at the patient level, patient care level, but it is somewhat static and known, and it does not adjust. For instance, it did not adjust to the pandemic in any way. Your budget was basically the same throughout the pandemic. In this case, because the pandemic had an effect of lowering costs, that created some benefit to people who were at risk. But if it had been a different type of pandemic that perhaps increased healthcare spending for the population, that would have been a risk factor. Under the fee-for-service models, those spend levels are allowed to flex with what's happening in the broader market. Again, I think this will be an issue going forward. If we do get 100% covered under risk, we might not have that nice fee-for-service reference trend that we have right now. But essentially in the ACO programs, you're being attributed some portion of lives, and you're getting a budget for them, and that budget is being updated based on a reference trend. So you're really being held to a reference trend. Don't trend more than this over your historical levels. And that's really the methodology of risk. A big thing to consider on the ACO side in the fee-for-service model is that attribution is king in this model. There is no enrollment. There's no open enrollment. Patients aren't choosing to come in and be attributed to a plan as they are in MA. And I'll get into it. There is some voluntary alignment, but largely patients are being attributed by Medicare at the high level based on what they deem to be primary care services. So you're getting attributed patients who you have treated either in past years or in the current year. The interesting wrinkle to that, in the most recent ACO REACH program, there is this concept of voluntary alignment that we've seen be quite important to those who aren't receiving traditional claims-based alignment. What that means is, for a patient that you have treated and are treating, you can ask that patient to voluntarily enroll with you as an ACO. I think there's some barriers to that. A lot of patients don't have awareness of what that is. It's not like choosing an MA plan where hey, it's open enrollment. I'm going to go and choose one. I need a plan. I've got to go choose one. Voluntary alignment, oftentimes the patient won't have a great sense for what they're voluntary aligning to. They may trust the doctor and be able to have it explained to them, but it will be some sort of educational process to get that patient to understand what it means. It doesn't affect their care. It doesn't really have any direct impacts to them. But if you're not going to get claims-based alignment directly, which is something we can model, Medicare models it from their 100% claims data. We at Milliman and other entities within the space have that data as well. We can tell you how many you'll be claims-based aligned. If that's not enough, or that doesn't cover enough of your population, then voluntary alignment is another way. And the voluntary aligned patients, their budget is set in much more in an MA way, since the process is similar to MA, with a regional rate based on their risk score. So just kind of to sum all that up, what we find is essential for provider groups looking to take on risk in this space, or understand what risk they could take on in this space, really important to get a clear picture of what your fee-for-service patient base looks like. How many are in fee-for-service versus MA? It's going to be a very different process to take risk for the MA lives versus fee-for-service lives. Might, in some ways, be more readily available to take on more risk for the fee-for-service than you would in the MA. Again, the MA is going to be a negotiation. So what does my current patient base look like? How many would I be claims-based aligned by CMS's methodology? It's not always clear. You wouldn't have a great sense for that inherently. How many would be claims-based aligned? If I can't get as many as I want claims-based aligned, who could I approach to get voluntary alignment from? And do I want to take voluntary alignment from? Are they priced well in this program? Those are all questions that can be answered through analysis of the 100% claims data set that CMS has made available to Milliman and many other parties. So that's really the key first step in planning here, is understanding what your patient base looks like, whether it is by default well priced in the fee-for-service methodology. And if not, are there steps you can take to either better code or take risk for a subsection of that population that is well priced?
I echo a lot of that, Jonah, especially with the groups we work with. A lot of our primary care groups that are clinic-based, they could have 2,000 to 3,000 patients in their panel, which a large percent of those patients they will not see annually for an annual wellness visit or have that voluntary attribution. So if you're the ACO or you're Medicare and you're looking at it, you might think that's your patient, but when you get into the black and white of it, it's hard to make that argument. So sometimes the claims-based isn't there, and that's why the importance of the voluntary annual wellness visit is critical. And so groups might think they have 30,000 or 100,000 patients, but the key question is, how many of those patients are actually attributed to your practice across the various plans? I think when we parlay that discussion, Dustin, into the valuation of a covered or an attributed life, when we look at a group, or investors look at a group, or payers look at a group, how does that work? And maybe if there's a few deals that you've seen in the primary care space that have transacted, what stood out to you?
So the one difference with primary care, I would say, versus the traditional specialty is there are many ways to value it, and value per patient life is what we see most common compared to a lot of other specialties. We're seeing adjusted EBITDA multiples applied. And those value per patient life, as it was just mentioned, the most important thing is really what are our attributed lives, because we're not placing a value on all lives. It's more of a value on the attributed life. And there is different values placed depending on the payer. A Medicare life is going to have different value than a Medicare Advantage life, a commercial life, and a Medicaid life. And that's when we see deals occurring, why there can be such vast differences among those deals, because a group that is all Medicare Advantage is going to have a much higher valuation per life than somebody that is Medicaid life. Commercial kind of falls into that middle when we look at those values. Now, ultimately, there are a lot of other factors that can come into play, such as revenue, which closely correlates to maybe how many physicians we have, as well as the number of offices or the spread. Ultimately, if we have a wider population reach, we're going to be able to obtain more lives in the long run and the growth opportunities. So as we look at valuing this scale and growth profile, the number of lives attributed, and the value-based care opportunity, because we are seeing deals within fee-for-service and ultimately modeling out what the value-based care opportunity is there. So you don't have to already go all the way up the risk curve to full risk or even just upside risk to have a model created that would allow you to transact at, I'll say, a premium valuation as you look to monetize on these profits available to a buyer by modeling out these patient lives.
Yeah, I think another factor too we see a lot here at Provident is groups that have, say, 100,000 lives. Having those lives in one market or two markets is generally much more favorable or advantageous than having 100,000 lives in 8 states. That just sort of stems from working with the payers or the ACOs or the different funding sources in your market. When you have lives at scale with a smaller cohort of payers, that's generally more favorable. But when we look at deals that have happened just, even this year, CVS Health buying Oak Street Health for $10.6 billion with only having 224 members, right? That's $47,000 per member, right? I think a lot of people get caught up in those metrics, but going back to, I think what Jonah was hitting on, there's a fundamental aspect to this where you have to, with a group like a Milliman and other analyses, look at what is the total cost of care of my patient population, what is the appropriate benchmarks, and in various financial arrangements with different models, what type of savings or PMPM could we drive? Jonah, anything else you would add before we wrap up here?
No, I think you've largely covered it there. I think it's essential for groups to understand both the volume of their total population, who they could automatically get attributed, who they may be able to get attributed, and again, understand the risk, total cost of care profile, and the likely benchmark they've received for those lives. Again, a very high cost life could actually be quite valuable. Maybe the benchmark is also high enough or even higher than the expected expenditures. Or maybe the opportunity for care reductions or care interventions there is very high, making them a valuable life, right? So it's not simply that historically less expensive lives are more valuable and historically more expensive lives are less valuable. It can go in between, really based on the numbers. And yeah, what we found is success in this space has involved getting the information. It's out there, it's available. Let me understand who my patient base is, how many are in MA, how many are in fee-for-service. Of those in fee-for-service, what does that risk and cost profile look like? And what might my benchmark be if I were to perform in one of the various program options there?
I mean, this is a topic that we could go on for hours about. Again, it's incredibly dynamic, it's evolving, so much to unpack. But with that, we appreciate everyone tuning in here. You can reach myself at csager@providenthp.com, Dustin at dthompson@providenthp.com, and Jonah at jonah.broulette@milliman.com. Really, thanks everyone for listening here and look forward to staying in touch. Thank you.